Yeah, so hi everybody, welcome to our long-term care learning series. It's a beautiful Friday. Hopefully you guys are getting ready for the end of the day and a nice weekend. I'm Sarah Metcalf. I'm one of the program managers in long-term care, and I'll be moderating today's session. Just a reminder that this session is being recorded so that you'll be able to access it later on if you'd like, either on our YouTube channel or on the intranet. First of all, I'd like to acknowledge today that I'm a visitor working on the traditional unceded territory of the Lekwungen people, known as the Saanich, Songhees, and Esquimalt peoples. Please take a moment to reflect and acknowledge the land that you're joining us from today. I want to thank you guys for taking the time to join our learning series today. April is our advanced care planning month, and Marina and I are very excited to have Jacinta presenting to all of us on National ACP Day. Jacinta is the advanced care planning and MOST coordinator with the palliative and end-of-life care program. And if you have any questions you'd like to ask, please just post them into Slido, and we'll go through those at the end of the presentation. So that's at www.sli.do, and the event code is #ACP. So without further ado, I'll hand things over to Jacinta.
Thank you. Sarah's right. I do sit within the palliative and end-of-life program, but my job really spans the whole island in all programs because as this year's national theme says, advanced care planning is for everyone. We should all be thinking about what matters most to us and what would matter for our care. I was telling Marina and Sarah that I was very enthusiastic this morning in adding things to my presentation. So I'm hoping that we have enough time. I have till just after 2:30 with you. So I will just get started right away. Okay, so as Sarah said, I'm the coordinator for advanced care planning and MOST, and my background's in social work. So this is something that's near and dear to my heart. I started in social work about 14 years ago for Vancouver Coastal Health. And there's just been so many experiences where I've seen the challenges of advanced care planning, and I've also seen where the information has been so useful and helpful when people are needing to make decisions or they're in crisis. So I think it's one of the best ways to make sure that our patient, client, resident voices are heard and respected in our settings. If you ever attend a session with me on advanced care planning, you will always see this definition. This definition came from a panel of about 52 clinicians, researchers, and policy leaders from 4 different countries. And they were initially pulled together to assist with some research related to identifying and ranking the outcomes of advanced care planning. And the research team decided that they would use the Institute of Medicine's definition of advanced care planning. But when they brought together this group of 52 people, they found that not everybody agreed on the definition. And so they went through numerous panels, discussions, qualitative analysis, and this was the definition that they all ended up agreeing on. So first, advanced care planning is a process that supports adults in understanding and sharing their personal values, life goals, and preferences for future medical care. The goal of advanced care planning is for people to receive care that's consistent with their values, goals, and preferences. And it may include appointing and preparing a person to act on their behalf if they become incapable of speaking or acting for themselves. So the reason that I always share this definition is that so often we get stuck on that point number 3 before we do anything about 1 and 2. So we get really caught up in who's the substitute decision maker, is there paperwork, maybe the social worker should talk to them so we can get paperwork. But if we haven't done the work of understanding the personal values, life goals, and preferences, then the paperwork doesn't really do a lot to help us. It simply names a person. So I could name Marina as my representative for my healthcare decisions, but if I don't talk to her about what actually matters for my healthcare, what my goals or preferences are, it doesn't really do her any good. It just tells the healthcare team that she can make decisions for me. And it also doesn't inform my healthcare team what I actually want. It's just saying, here's a person you can talk to. So it's not effective unless points 1 and 2 happen. And then if somebody chooses to complete some paperwork for substitute decision making, that can be part of the process, but it shouldn't be the focus of the process. This is just a visual that I like, where you'll see that the person's values, wishes, beliefs, and goals for their care, that's going to run the care continuum. It's going to span the person's life. So those advanced care planning conversations that we have, where we're finding out what matters to somebody, what they value, who their important people are, if they have spiritual, cultural, religious beliefs that affect their care, all of those things will influence future goals of care discussions. So if somebody has a chronic or life-limiting illness, the advanced care planning discussions create the foundation for those. Then we're going to build on it as we get more information. And then it also helps to inform any decision-making or consent decisions that we need, or decisions about treatment. But wherever a person is in their healthcare journey, we should always be aware of their values, wishes, and beliefs. There's many benefits to advanced care planning, including that people report having more satisfaction with care, reduced anxiety, fewer hospitalizations, fewer ICU admissions. We've also found that staff report lower moral distress with having advanced care planning information, because when we know what somebody wants and we give it to them, that makes us feel a whole lot better than, I don't know, I hope we did the right thing, or that was just really aggressive and terrible to watch and I feel really awful about it. So it's not just for the sake of our patients or residents and their families, it's also for our own sake, to make us more confident in what we're doing. So in BC, this was a study that was done in 2020. This was a study that was commissioned by the BC Centre for Palliative Care. They found that 76% of British Columbians agree that it's important to talk about what matters most for their future health care, but only 48% have talked about it with their family or important people. Only 28% have actually documented it, and then only 14% have had a conversation with the healthcare provider about it. So this tells me that, well, when we think about the research that's been done around this, patients, residents, clients, they expect us to start the conversations. They feel like if we need information or they need information, we will initiate that conversation. It would be very rare for someone to go to their physician or nurse practitioner and say, you know, really been thinking about what's important to me and I want to share that with you. They know that we're pressed for time. They know that somebody else is waiting for our care after they see us. So it's really important that we initiate the conversation, or that we're actively seeking that information from the people who are in front of us. And the other thing that I'll say to that is that this doesn't all have to come at once. So if you're working together as a team and all of your team members are involved in having these conversations, you're going to build a record and you're going to build an understanding together as a team about what is important to this person and what's going to be most relevant to their care. It's even if you were to have a whole discussion in one day about advanced care planning, it could change in a few weeks. It could change the next day if there were a health event that changed that, or a family event that changed that. So that's why it's important to keep the conversations going and have everybody on board with doing it. So one of the things that comes up with advanced care planning is that third point, right? So we've talked now about points 1 and 2, but that third point about appointing a substitute decision maker often becomes important for us in healthcare. And so this is some of the terminology that's used in BC around substitute decision making. And I always feel like it's important that we use the appropriate language. And the reason is that, and I'm sure you've seen it, you'll see in charts, it'll say, so-and-so is SDM, But that doesn't really, for me, demonstrate that we're really clear on who we're getting consent from. SDM is kind of a really vague term, so is next of kin. What I want to know is, if we're going to go to this person for consent, what authority do they have to make those decisions? So I'm not just sort of basing it willy-nilly on who I think or what's written under the next of kin on the face sheet. I'm thinking about, there's a decision that needs to be made and I need to know the appropriate person to go to. So it looks like committee, but it's a committee or guardian of person. This is the most intrusive way for somebody to be a substitute decision maker. This is court appointed, and this usually happens after somebody, well, it does happen after somebody has been deemed incapable of making their own decisions, whether for care, healthcare, or for finances and legal decisions. So this would mean somebody applying to the court to become committee. It's an expensive process, and it essentially removes all rights from the adult. So that's the one that we want to, if we're having conversations in the future, or sorry, if we're having conversations in the present, it helps to inform the future. So if I appoint a representative now, for instance, and I lose capacity, that representative acts in my place. But if I don't do any of that and I lose my capacity and I need help making decisions, then somebody can apply to the courts to become my committee. The representative is essentially assigning somebody that you trust to say, I want this person to make medical decisions for me if I'm not able to make them for myself. And there's two forms of a representation agreement. One is a Section 9, and that's made by capable adults. And it basically is giving the authority to the person that you assign to act as you would act. They have access to the same information that you would have. They can make decisions as you would. And that includes decisions up to decisions about life-preserving treatment. Section 7 can be made by people who have limited capability or don't meet the standard criteria for capability. It provides a lot of the same authority that the Section 9 does, but it does not include decision-making capability around life-preserving treatment. But these people who act under Section 7 can make decisions about care and treatment. Anybody can make a Section 7, but this was largely designed by the developmental disability community. They advocated for this because they said, we are able to demonstrate that we know who we want to make decisions for us, that we have people that we trust to care for us and make decisions on our behalf or help us make decisions. We need something that we can legally appoint somebody to do that for us. And this can be helpful for people who have cognitive impairment or brain injury, where they're able to demonstrate things like having a trusting relationship with the person, that they want to have somebody make or help them make decisions on their behalf, that they understand the representation agreement means that they're giving somebody that authority. So there's some safeguards in there to ensure that the person actually knows what they're doing when they sign that paperwork and that they want to do that. An advance directive is basically a legal form that says, I will consent to this and I won't consent to that. So you can list different interventions or treatments that you would or would not consent to. It has to be really specific. So I can't say something like, don't let me live if I'm going to be quote unquote a vegetable, which a lot of people use that terminology, but it's not really helpful to us. An advance directive needs to say something like, I do not consent to blood transfusions, or I do not consent to artificial hydration and nutrition. So it has to be really specific. And if somebody has, if there's a consent decision needed around something outside of what's listed in the advance directive, then the advance directive doesn't guide care. And then there's temporary substitute decision maker, and that's that hierarchical list. So if I don't have a committee or a representative or an advance directive, then we're going to go to the temporary substitute decision maker, and that's the spouse, child, parent, that list. And it's the healthcare provider who chooses from that list, and it's decision focused. So we don't just write in a chart, so-and-so is TSDM forever and ever, amen. It's when we're looking for specific decisions, we need to go back to the list and choose the appropriate person to make the decision, get a decision, and then start again. And there's guidelines within the consent legislation around how long that period lasts for someone to be TSDM and how long the decision is good for, and so on. But we won't go into all of that today. But if you have questions about consent and how these pieces work in the consent process, this guide, the Healthcare Provider's Guide to Consent to Healthcare, is issued by the Ministry of Health, and it talks about each of those things, like the committee and the representative and so on, and how they fit into decision making. And at the back of the booklet are these helpful algorithms. So this one that I've put in here is a pretty simple one. Is it possible to obtain consent from the adult? If yes, great, we're going to get consent from the adult. If not, we're going to look to see if there's a personal guardian or committee. If yes, we're going to get their consent. If no, okay, next on the list is their representative. And so these algorithms, I think, are pretty helpful in making the process clear. Now we get into the legal and financial piece. And again, these are things that can be part of the advanced care planning process. So as somebody's thinking about what's important to them, as they're thinking about who might make decisions for them, some of these pieces around, okay, well, if I'm going to appoint somebody to represent me for my healthcare, I should probably think about someone representing me for my legal and financial decisions. And so the first thing is people could appoint a power of attorney or an enduring power of attorney. The difference is simply that the enduring means that if somebody loses their capacity to make financial decisions, then it endures beyond that. So the power of attorney continues past any loss of capacity. So if you see something in a chart, or if somebody says anything about being power of attorney, so I've seen, and I'm sure you've seen, the things that say daughter is POA, and there's an implication in how that's written that this is important to the healthcare. It actually has no bearing on healthcare. It only has bearing on legal and financial decisions in BC. There is a representation agreement, section 7. So if we go back, that's the one that people who have limited capability or don't meet the standard criteria for capability can complete. There is one for financial legal. That requires that there's a monitor assigned. So if somebody appoints another person as their Rep 7 for financial legal, someone has to monitor that they're doing that job appropriately. So if you receive a section 7 representation agreement, just make sure that it's the right kind, that it's healthcare. And then there's wills, which I'm sure I don't need to say this to all of you, but the will, of course, is for people's estates after they die. And I've worked in palliative care, and I have had people say, "Oh, well, I'm the executor of the estate. I'm the executor of the will, so you can talk to me about what's going on with the healthcare." But the will only comes into effect after a person has died, so we can't use that as a substitute decision maker in healthcare, although there may be other reasons why the executor might be an appropriate person to make decisions, like they might within the TSDM list be the appropriate person, but it's not by virtue of the will alone that they have that authority. So this is just a helpful little image that we use a lot in our advanced care planning teaching around how this all relates to the most. So the most we talk about the most is just the cherry on top of the sundae. And similar to the paperwork for advanced care planning, most is one of those things also that we think, oh, we've got to have a most on the chart. Everybody needs a most. And for residential care, that's probably true, but we don't want to have that be the only thing that we're focused on. So we think about the advanced care planning and the goals of care information. That's the sundae, that's the ice cream and the chocolate sauce, the really good part. But it's the cherry that's the most. So it's taking what we already know, it's taking that knowledge of the person and what's important to them and what they want in their lives, and we're just putting it in a designation. What ends up happening, unfortunately, is that we get cherries in empty bowls. So we don't get any of the rich conversation around who the person is and what they value and where they want to go with their care. We're just getting the cherry. There was a study done out of Alberta where they have their version of MOST is called the Goals of Care designation. They found that 98% of the people that they surveyed had a goals of care designation, but only 36% of them knew that they did. They didn't really know that they'd ever had a conversation about goals of care. And only 30% of those were actually in line with what the patient wanted. And most of the time, they were actually more aggressive than what the patient themselves would have wanted. So we can't assume that when we have that cherry on top that we actually have the ice cream and the chocolate sauce accompanying it. Lots of times we only have the cherry. So it's still important, even if you see a MOST, it's still important to do the legwork of scooping that ice cream and getting it in the bowl. These were some of the resources that I find helpful for advanced care planning. There's lots out there. And if you Google it, there's like close to 500 million results about advanced care planning. And that's because it's a worldwide concept. And also the language is different even in different provinces in Canada. So these ones are more BC oriented. There's My Voice, which I'm sure many of you have seen, which is issued by the Ministry of Health. And then there's also Your Care, Your Choices, which is fairly new. It's about a year old. And that came out of the First Nations Health Authority. And it's designed for people who identify as Indigenous, First Nations, Métis, Aboriginal. So if you're working with people who identify in that way, that could be a good resource to bring forward. It's similar to the My Voice in that it has all the same paperwork in it, and it talks about the different things that people can do to make an advanced care plan, but it also uses the tradition of storytelling in making it apparent why somebody might want to make an advanced care plan and why it might be important. So I love it. It's an excellent resource. It's Your Choice is issued by the Public Guardian and Trustees Office of BC. It's more of like the legalese. So it's not like a light read for clients or residents, but it does, I think, explain really well how how the consent and advanced care planning documents work together. And there's a helpful little chart in there that will show the type of decision-making ability a person has and what authority they have. So if it says power of attorney, it'll say yes, they have authority to make financial and legal decisions, but no for personal and healthcare decisions. So that's a helpful little tool. We've talked about this guide to consent to healthcare. HealthLink BC has some good resources for advanced care planning. In particular, at the bottom of the page, there's some information about different interventions and what they actually mean. So CPR, artificial hydration and nutrition. Because the thing is that some people say, they think about interventions that they would or wouldn't want, but they don't actually understand what it means. So an example would be that recently I had a call from a gentleman who was in his 80s, and he said, well, wouldn't everybody want CPR? And I said, well, maybe not. We talked about the fact that sometimes it can cause damage, and sometimes, lots of times people don't have the same level of function as they did before the cardiac arrest. And I encouraged him to talk to his care provider about what that would look like in the context of his care and his health. But when people only have things like television or movies to demonstrate what some of these things look like, it's not reality based. And so those tools on HealthLink BC I find are helpful to kind of put it in layman's terms and help us to deliver the information in an effective way. So even if you want to read them, so you have an idea of how to deliver that information to people, that's helpful too. And then there's Speak Up Canada, which is the national website, which is just advancedcareplanning.ca. And the reason I have them there is that there is a tool on the website, and it's called Make My Plan. And people can actually go through and it asks them those questions about what do you value? Who's important to you? What gives you quality of life? What capabilities are important to you? It also will say, okay, well, you're in BC, so here's some paperwork you might want to consider. And then when people are done, they actually can just print it from the website and they have their advanced care plan. So that's kind of it's a helpful tool for people who are computer savvy. So now, you've gotten all the information, you know who the person is, you understand what's important to them, and now we need to document it. And as you can imagine, these things get documented in many, many different places. And we actually have an advanced care planning power form where all of this information can be charted. And when it's charted there, it actually gets saved in such a way that you can actually go to results review and see under the ACP Most tab, you can see all of the entries that have been done on the ACP Power Form. So one of the easiest ways to get to this form is through ad hoc. You can see the advanced care planning goals of care. And so you can click, 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 click close, and it'll open it up. Or sorry, not close, chart. And so that's one easy way to get there. And then another place is through the end page. So if you're pulling up a patient's chart, on your left-hand side, you'll see ACP. And we even have put there again, see most ACP tab and results review as a reminder. And you can click on the advanced care planning goals of care form, and that'll open the form for you as well. I'm not going to go through the whole form, but I'll show you in general what you're going to see when you go to that form. So the first page that you'll see is this goals of care narrative. And you'll notice on the top, there's a white box. That's where you're going to enter the free text information about, and actually in the blue at the bottom, we've got some prompts around what you might consider when you're writing in here. So you're going to chart it in the white box. And then what happens is it gets stored in that gray box down below when you save the form. So you'll notice I've got a note there that they've expressed a fear that the condition's worsening, they're noticing more fatigue and their level of function is reduced, and they're wondering if some of the medications might be contributing, wondering which medications are necessary and which they can do without, and saying that the amount of medication is burdensome, and they continue to express a wish to avoid going to hospital and being at home whenever possible. So that gets stored in the gray box. Then if I wrote another note in the white box and saved it, that's going to go in that gray box as well. So what ends up happening is we're getting this running record of what we're learning about the person and their goals of care. In the middle there, you'll see that smaller box. Those are all those pages that you can chart on in the advanced care planning power form. So the one to the right is the consent to treatment page. So if somebody's done something like a representation agreement, you can put that information in there. If they've done an advanced directive, you can put it there. You also can record potential TSDMs at the bottom of the page. I was a real stickler for making sure it said potential because relationships can change all the time. So somebody could be eligible to be a TSDM today. They meet all the criteria, meaning that they've been in contact in the last year, they don't have any dispute with the adult, they're 19 years of age, they're capable of doing it, they're willing to do it. All of those things can change at any time. So when we're looking at that TSDM list, we need to be mindful that we want to review it. So we want to say, this is what I have in front of me. Is that still accurate? And that's it. That's my crash course in advanced care planning. And I'm happy to take a few minutes to answer some questions. And I know Marina said that she'll also answer some if I have to go.
Thank you so much, Jacinta. Yeah, so Slido is open if you want to post your questions in there, or feel free to unmute and ask any questions you have.
Oh, it's a Friday afternoon in a quiet bunch. I had a question for you, Jacinta, and thank you for that. I learned a lot with that. So, and great presentation. Thank you. I have a question around the advanced directive, because you talked about, you need to be really specific about, you want CPR, but and not nutritional support, those things. Is there like a list anywhere, or how do people become that? Like you're saying, if people have nothing but television to let them know, what about healthcare? How is someone like that going to make those kind of decisions?
Yeah, it's a great question. So I think the HealthLink BC their tools are great for that, but I always encourage people to talk to their care provider about it. So if they have a GP or an NP and they say, I'm thinking about completing an advanced directive, but I don't even know what to put in here because I don't know what would be relevant to me and my health. That's also a good starting point. The other thing that people can do is they could also complete what's called a written expression of wishes, which is less precise. So that's where you can have more of that subjective, nuanced kind of writing about, this is what gives me quality of life, this is who I am, this is what would make living my life not acceptable to me. I really want to spend time with my family. Kind of that more personal approach. And so it's not a legal document like an advanced directive, but if you were to read something like that and we're considering a certain treatment or intervention for somebody, you might say, okay, well, based on this, might not be the best idea.
Thank you for that. And one more then.
Go ahead.
So I noticed that the charting that you were showing us was pretty Island Health specific.
Yeah.
And I know that lots of folks on here are from affiliated partners.
Yeah.
So are there any charting options for outside of Island Health that you know of?
I believe that, and Marina can maybe jump in here, there's still the paper form, the advanced care planning paper form. We're constantly trying to figure out if there's ways that we can get information from long-term care, from primary care, because we know that those conversations are happening outside of VHA facilities.
Yeah, and there's work going on, as you know, Jacinta, but for the benefit of everyone, there is an EMOST working group that's coming together to look at those conversations, particularly for sites outside of the Island Health owned and operated realm, where that documentation is most likely a bit more streamlined and accessible, and looking at how that EMOST information can be easily collected and entered into the electronic health record. So that has for sure been identified as a need and something that's actively being worked on right now.
Yeah, it is. And I think with that, it's there's just so many, there's so many residents and facilities, and it will take time, but something that we're trying to figure out how to not only get the information from you, but also get it back to you as well after people have been with us.
Thank you.
Can I ask a question?
Mm-hmm.
Thank you very much for that presentation. It's very helpful. I'm a social worker in long-term care at an activated power chart site, and we've been using the advanced care planning power forms quite a bit. One of the things that I have lots of questions, but one of them is, do you know if there's any plans for power chart to really try and bring that information even more obvious, like to the front page?
Yeah, I do know that on the M page that I showed you, for instance, so you can manipulate that to get it to the way that you want it, including deleting things, but you actually can't delete the most ACP one. It stays there regardless. And I believe that's the same for ad hoc. It will always show up as an option for your charting. But
I mean, more like I know how to find it. I'm thinking for when residents get transferred to the ER, which happened recently. I had an advanced care plan for that person and named who the TSDMs, appropriate TSDMs would be. And for some reason, when this person was admitted to the ER, their demographic sheet got updated and it put her ex-husband as the first contact on the patient demographic record. So they actually called him to get his consent to admit her involuntarily, which was totally inappropriate. And that was very clearly explained in the advanced care planning power form, but they didn't look there. So I wish it was just more front, like right in their faces when they get to the hospital.
And I think it's a great point, because those demographic sheets or the face sheet, that's like the next of kin or emergency contact. That's not necessarily like I could list my neighbor as my emergency contact because they're most available to me. But it's really like my daughter in Toronto that I want to make decisions for me. So I think that there's a piece around education of what these things actually mean and where that's ongoing. And then I think we're really trying to implement and socialize the ACP power form. So it's early days. But one example is that right now we're working on a video with the Sim Lab that demonstrates what information you can chart there, and then also demonstrates that you can see that information on results review and the M page. And we're going to be sort of blasting that out to everybody in Island Health. So it's just this gradual process of getting people knowing about it and using it. But unfortunately, that experience, and I don't think it's even related to the power form necessarily, it's just people see that first sheet and they go, okay, this is who I call, without that conscious thought about like, who am I getting consent from? And does this make sense? And what's the relationship? And that's also
one more question if there's still time for one more question.
Yeah, and then Marina, I'm gonna have to go just because my kids are waiting.
Oh, sorry. It was just about Nidus, and if Nidus is still somebody that we should be communicating with around the rep agreements, or they kind of fizzled out.
So this is what I'll say about Nidus. They have excellent tools, and I myself, when I was doing my more clinical social work, I used a lot of their help sheets for people if they're trying to understand like rep agreements or whatever. But one of the things that I struggle with Nidus is they're very paperwork oriented, and it's not necessarily the message that we're trying to convey from a Island Health perspective. We're really trying to get at those values, wishes, and preferences, and paperwork if it's needed and if it's wanted. And then the other thing is that they do a lot of promotion around their registry, which isn't always accessible to all people and all health authorities. So in terms of like the materials that they have, I think they've got good stuff out there, but it's just not something that I promote often, like in a public, with the public, for instance, just because I know that they're gonna get that messaging around paperwork.
Excellent. Jacinta, thank you so much. I know you
thanks for having me. And I'll just, I'll put my email address in the chat box here. So, if you walk away from this and you think, geez, I didn't understand this, or I need a little more information, that's what I'm here for. You can always email me and I'll get back to you as soon as I can on your question.
Wonderful. Thank you so much. And you have a great weekend, Jacinta.
Thank you too. Everyone enjoy the sunshine.
And we were super fortunate to have Jacinta today. As Sarah had mentioned, it is not only is it ACP month, but today is National ACP Day. You'll have maybe noticed some increased communications and publications coming out through Island Health about advanced care planning. So this is a great opportunity to use social media in a positive way and share the great resources that have been put out through our Island Health media and communications, if you've seen them. ACP also is really timely in the COVID environment we're living and working in right now as well. With the onset of the pandemic, one of the first recommendations that came forward as everything was evolving was that patients, residents, physicians, providers, nurse practitioners needed to sit down and revisit those most conversations in the context of COVID and what a person's needs, wishes would be in the event of a COVID positive diagnosis, knowing that intensive care and ventilation, it could be part of that treatment plan. So it really was a reminder for myself, but also for many people, just how important these conversations are to happen. They're not a one and done. They're an ongoing conversation where we're needing to continually check in. It doesn't need to be this formal sit down sort of meeting type conversation. We can be gathering bits of information that inform a person's goals of care and wishes in our day-to-day conversations. But that documentation piece, as Jacinta has shown us, is so important for that ongoing communication and building the story. The most status is one very small piece. It's that cherry on top. It's not consent to treatment. It's not consent to transfer. It's just an initial indication about sort of what a broad sweeping decision might be, but it's not the decision itself. So I really encourage you to not only, if your takeaway from today is to think about what your own ACP goals would be, or some things that you would have a conversation and just get more comfortable with these topics and how important they are to care, not just now, but how it informs your future care and that of your residents and patients as well. Were there any final thoughts or questions from the group? Sarah, I'll hand it back to you.
Great. Yeah, so I've posted a link to our survey in the chat box. If you guys could give some feedback on today's session, that would be great. You can also let Marina or myself know if you or your staff have any requests for topics that you'd like covered in this learning series. We're always looking for new ideas. So yeah, send those our way. But yeah, other than that, thanks so much for joining today. I hope you guys can get out in the sunshine soon and enjoy your weekend. Take care, everybody.